Michael, as we continue our launch into the stratosphere with Oncology of the Inquisitive Mind Lung Edition, we are going deep into all of the lung trials, which over the last decade, not the last week, I said that last take, the last decade have really come a long way. And it's a fascinating area. Michael will be talking about the c-MET inhibitor and the c-MET, I guess, lung cancer. And I'll be talking about the KRAS trials. But Michael, I'm not going to make a fool of myself this time. Do you want to give us a little bit of information about the c-MET and your insight into how tepotinib might have changed how we treat this drug and this type of cancer?
Absolutely. Hello, everybody. A much less rambly introduction this time. If you listen to our last episode, you know that I completely went off the reservation for a bit. But that's why we get Josh to do the punchy stuff, because he's much better at it. I am going to be talking about a study that is very insightful, Josh, because it's called Insight 2. And it is focusing on MET mutant non-small cell lung cancer, which is a very rare but important, increasingly important clinical entity. So a bit of background. So MET is a tyrosine kinase receptor for hepatocyte growth factor. And like most of these sorts of names, as far as I could tell, HGF, hepatocyte growth factor, has very little to do with hepatocytes and their factor of growth. Could be wrong about that, but it seems like these factors are just named by picking names out of a hat to me. Anyway, so the binding of MET to HGF activates downstream signaling pathways and plays an important role in cell proliferation, survival, embryogenesis, cellular migration, and invasion. It's the usual song that you hear from these activating oncogenic mutations. It can also lead to downstream signaling through the RAS, RAF, and PIK3 kinase pathways. And the most common variations in this signaling pathway are point mutations, amplification, exon 14 skipping mutations, and fusions. The exon 14 skipping mutations, I'll mention them specifically because that is actually the PBS requirement for access to tepotinib, which is the drug that we'll be talking about. These are found in approximately 3% of lung adenocarcinomas, but the rare sarcomatoid subtype of non-small cell lung cancer contains up to 20%. 20% of cases contain a exon 14 skipping mutation in MET. So if you happen to have a sarcomatoid non-small cell lung cancer, make sure you check MET. MET gene amplification is found in 2 to 4% of treatment-naive non-small cell lung cancers, but for patients who have had EGFR mutant tumours and have had acquired resistance, 5 to 20% of these patients will have MET gene amplification. So it's important that if you have a patient who's progressed on an anti-EGFR, you again biopsy them, check them for MET. Just think of it as the new T790M mutation. So tepotinib is a daily highly selective oral MET inhibitor. And Insight 2, which is a study that I'll be looking at, is an open label phase 2 study examining patients who are receiving a combination of tepotinib and osimertinib. It's only a single phase study, but after they've progressed on first-line osimertinib. Before I jump into that, very quick side note about vision, because I mentioned MET exon 14 skipping mutations, another single-arm phase 2 study. This demonstrated the efficacy of tepotinib in patients with a MET exon 14 skipping mutation, overall response rate of 46%, overall survival of 17.1 months, and that led to the registration of tepotinib in Australia for MET exon 14 skipping mutations. And I promise that's the last time I will say MET exon 14 skipping mutation this episode. So in terms of Insight 2, patients who were enrolled had locally advanced metastatic non-small cell lung cancer with an activating EGFR mutation. On a repeat tissue biopsy, they had to have a MET amplification, and this was done by a tumour biopsy with fluoro in situ hybridization or FISH. They had to have an acquired resistance to first-line osimertinib with objective clinical benefit during prior osimertinib, and I think that was defined as greater than 6 months on treatment. So 120 patients were enrolled, 99 of those were included in the efficacy analysis. So they were randomized 2-to-1 to receive tepotinib plus osimertinib. The randomization for this is a bit weird because they had a number of patients who had a liquid biopsy NGS, or only a handful. These also had tepotinib plus osimertinib, but then they had 12 patients in a safety run-in group and they received tepotinib alone. We'll take those 12 and put them to the side and just sort of think about it, easier to think about this study as everyone receiving tepotinib plus osimertinib after progression. So in terms of endpoints, the primary endpoint was overall response rate. This is a small single-arm study, so you tend to look at overall response rate. Secondary endpoints were duration of response, progression-free survival, overall survival, health-related quality of life, and safety. In terms of demographic notes, the median age of patients was 61 years old, 58% were female, 62% were of Asian heritage, 67% had never smoked. So very typical EGFR mutant cohort. 35% of patients had brain mets, and in terms of the subtype of EGFR mutations, 59% of patients had EGFR exon 19 mutations, exon 19 deletions, I should say. The median time on osimertinib in the first line was 15 months. The overall response rate from the combination of tepotinib plus osimertinib was 50%. Tumour shrinkage of any magnitude occurred in close to 80% of patients. There were no complete responses, however, which is a little bit disappointing. Median duration of response was 8.5 months. Median progression-free survival was 5.6 months, with a 9-month PFS rate of 30%. In terms of the intracranial overall response rate, little under a third, 29%, but 25% of that 29% had an intracranial complete response, which was great. In terms of safety, the most common side effects associated with the combination: diarrhea, peripheral edema, paronychia, nausea, and decreased appetite. The most common grade 3 adverse events were peripheral edema, prolonged QT syndrome, decreased appetite, and pneumonitis. But none of these individually had an incidence of greater than 5%, so pretty well tolerated. And because it's a combination, it's difficult to tease out whether it's the osimertinib or the tepotinib. Tepotinib, I think, in clinical practice can be quite toxic if you have a reduced performance status. So use it with caution, pick your patients, as we always say. But in this study, it seemed to be fairly well tolerated, but you can probably say that with pretty much any study. So it's an interesting study. It goes without saying, in these patients, it's always better to delay needing chemotherapy for as long as possible, because chemotherapy usually doesn't work with mutant non-small cell lung cancers. This is, of course, being thrown into an increasingly congested clinical picture with, as we saw last week, with the arrival of amivantamab plus lazertinib, osimertinib plus chemotherapy. And so you've got a lot of options that don't involve chemotherapy, or aren't emphasizing chemotherapy, I should say, giving you more time to avoid or put off the dreaded quadruplet chemotherapy, which of course is what we always used to use on the basis of pretty shoddy evidence, if we're honest, after progression on first-line EGFR. So it also highlights the importance of rebiopsy post-progression on EGFR. We used to do it for T790M mutations. Now we're looking for MET mutations. And that's it, Josh. I mean, and the reason that I wanted to talk about it was because it's not something that I think a lot of people who don't have a lot of experience in lung cancer think about. You know, they think of EGFR, ALK, ROS1. If they are up to date, they might think of KRAS, which is what you're talking about, but they don't think about MET.
No, it's not the common one. So you wouldn't expect everyone to be like, oh, yeah, I've treated all these MET cancers. Like it's
treated 5 in the last week.
Yes, 500 in the last day. No, so look, really, yeah, you're right. At least it's a drug. I get it's toxic, but lung cancer, when not treated, is absolutely horrible.
Absolutely. And again, it's not a chemo drug, so probably a good option. Anyway, why don't we go from one of the least common mutations, Josh, to the most common mutation in non-small cell lung cancer, and that's KRAS.
Yeah, that's right. You must have a crystal ball of what we're going to talk about next. Oh, Michael. So the background is there's lots of different mutations, which I think you're probably getting from this little mini series that we're doing. And the thing is that first line, you've had chemo, you've had immunotherapy, and then second line, you don't have a lot. You've got docetaxel, which has been around for donkey's years. And in the second line setting across the board for non-small cell lung cancer, response rates are somewhere between 6 and 20%. And a median progression-free survival is somewhere between 2 and 4 months. So a scan. And, that's either probably docetaxel or single agent pemetrexed. Interesting enough, KRAS mutants, depending where you look, is somewhere between 15 and 30% of all non-small cell lung cancers. I say that because if you look at different studies, they have different statistics. The most common of that would be KRAS G12C, which, when active, leads to hyperactivation of the downstream oncogenic pathways for uncontrolled cell growth. So KRAS mutations, bad. Treating this, good. This specific mutation represents about 50% of all KRAS. So there's two studies I'll talk about, Michael. One because there's sort of no overall survival data yet, and the other one because we should talk about it. The first is the Crystal-1-2 study. So it's those that had locally advanced or metastatic lung cancer with KRAS mutant, non-small cell lung cancer, of course. Had to have a prior treatment with a platinum-based chemotherapy and an anti-PD-L1, which represents the standard of care. And stable brain mets were allowed, and you were randomized 2-to-1 either to the intervention drug. So it's adagrasib versus docetaxel, with the primary endpoint being progression-free survival and all of the secondary endpoints that we know. So the key finding is that of interest, 29% actually crossed over from the standard of care after confirmed disease progression, and the median follow-up at this time of reporting was a short 7.2 months. But it met its primary endpoint, A, showing that we need better treatments, and B, showing that we've got a long way to go to things like osimertinib and lorlatinib as an example. So progression-free survival is about 5.5 versus 3.8 months with a hazard ratio of 0.58, so 40% plus better. And the objective response rate was 32% versus 9%, so a lot better in that cohort. And disease control rate was in the high 70s versus the high 50s. So again, you get at least a 20% plus benefit. The median duration of response was 8.3 versus 5.4 months. And sustained response at 6 months was about 64% versus 39%. You also saw an increase in stability for those with intracranial mets in 24% versus 11%, favoring adagrasib and docetaxel being the latter. Time deterioration was delayed as well using adagrasib, and toxicity, while GI tox was more common than that of docetaxel and vomiting, it also had a better outcome. So you sort of have to take that sort of hand in hand for a first generation drug. At the 6-month mark, with a progression-free survival, 45% of patients had not progressed versus 30% in the standard of care arm. And that, consistent benefit across subgroup analysis, which is really exciting. Here comes a little tricky bit, right? Because we need a confirmatory, well, this is a confirmatory phase 3 trial, but we don't have overall survival data. So we know it's superior to docetaxel. We know it's somewhat similar to sotorasib or sotorasib, however you want to pronounce it, and we'll talk about that a little bit, but it's not astronomically better. We know the CNS activity, but also we know it's not hugely more beneficial than the standard of care arm, what is a very, very expensive drug. And then if you do a head-to-head comparison versus its older and grandfatherly cousin, you see some interesting points. That being, if you look at the progression-free survival, it's pretty much smack bang in the middle. Well, it's the same. So it's 5.6 versus 5.5 months, favoring the Codebreak study, which was sotorasib. The overall survival, or not mature yet, was 11.3 months in the sotorasib or Codebreak 200 trial. And then if you look at overall survival, the first KRAS, while better from a progression-free survival, wasn't actually better from an overall survival data. So you delay time to progression and maybe you delay toxicity, but ultimately it's another drug that you can use, but it's not necessarily better than the standard of care. And so that's really an interesting point. Oh, sorry, Codebreak 300 trial. I'm doing well. There's my third mistake for the series. The Codebreak 300 trial was randomized sotorasib of different sort of doses and then investigated choice of sort of late line therapy. And I think it was Lonsurf they used, or regorafenib, Michael, not docetaxel. So again, a different control arm. So how do you take that into account? I don't really know.
That is for colorectal cancer. You didn't know that, right?
But if you look at the Codebreak 200 study, which is again versus docetaxel, the interesting points with this is that the actual progression-free survival and overall survival wasn't astronomically better. It was about on par, if not a little bit worse than historical docetaxel. And so the question is, this drug is available, it's a second line setting. How does this fit into our sphere? And I think you can still use it because you'll have people who will respond astronomically well, but there are also those who may not respond as well. And so you have to kind of ask this question for a drug that costs a lot of money and potentially has still got its own set of toxicities and probably less toxic, but how would you include this in the treatment paradigm? But what it is saying is that we've got this target and we probably need better drugs.
Yeah, completely agree. And it's so frustrating because there's clearly more to KRAS in lung cancer than meets the eye. And it's clearly a different clinical entity compared to KRAS in colorectal cancer, as an example. So we haven't found the silver bullet for this clinical entity yet. The answer will probably be some sort of combination. And, do we add it to chemo plus pembro in the first line? I don't know. But we are yet to crack this particular nut.
That's it. And I think the other thing with the code break study, which is interesting, is that the earliest studies actually had a better benefit. So the phase 1 studies actually showed a more robust response. And whether that is purely because it's a phase 1 study, yeah, probably is.
That strikes me as a smaller numbers, and you just happen to pick a group of people that responded better. But when you're getting bigger numbers, more data, the benefit is being attenuated somewhat.
That's it. So look, really, really interesting, Michael. And I think what's even more interesting is what we're doing next week.
Absolutely. So we've been talking about non-small cell lung cancer for the past few weeks, but we're going to shift focus to its older, nastier, more aggressive brother, which is small cell lung cancer. And we're going to talk about limited stage small cell next week with a couple of very interesting studies. I know I say that every week, but I genuinely mean it this time. And then the week after, we'll be talking about extensive stage small cell and what improvements, if any, there have been, because unlike non-small cell lung cancer, Josh, unfortunately, small cell has been in a bit of a rut for the last little while.
Yeah, orphan cousin.
Orphan cousin, I think that's a better way to describe it. But we hope you will continue to follow us on this back to basics journey. It's been fun. We love doing it, and we hope you are enjoying it so far. There's still a hell of a lot more to go.
Yeah, no. Only scratching the surface, Mikey, but see you next week.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more, at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.